I am going to kick this off and then hand this off to Archana. But again, as I mentioned, we are taking a deeper dive into the role of the primary care physician from the perspective of practicing physicians or formerly practicing physicians. We talked a lot about economics in the first panel. This time we're going to talk about, we'll talk about the different approaches, but we really also want to understand from the provider standpoint and from the patient standpoint how things are changing. How are we delivering better outcomes? Are we creating more trust between the doctor and the patient? Are we alleviating doctor burnout? So with that, I'm going to shift this over to Archana, who's going to do the introductions. Archana.
Yes, absolutely. Welcome all of our panel here. Really excited to see my partners in crime in a way, especially Donna, because we sit on the payer side. So the rest of the folks can have slightly different perspective, but would love to have introductions, a brief introduction from all of you, and we'll go around the tiles that we see on the Zoom, and would love to hear from you. Why did you, with your knowledge and expertise as a physician, chose to innovate? So from a provider, you became an innovator, and what was kind of your pivot moment in a way? And how are you powering up the quarterback, which is the primary care provider in your space? So what does your company do, and how does it relate to the topic today? So I will start with Adrienne, because you're on my right side. So I'll put you on the spot, and you're on mute. So you have to unmute. Yeah.
Great. Thank you so much. So I am Adrienne McFadden. I'm the Chief Medical Officer at Buoy Health. And I would say that I made my foray into the innovation space, mainly sort of hearing the old Einstein quote about insanity, right? Doing things the same way and expecting different results. My background practicing is actually as an emergency physician, but I realized that a lot of what we were doing was a resurfacing of the same types of things that we had done in the past with potentially different nomenclature to it. And what we were experiencing was pretty much the same results and not really getting very far what we thought the healthcare system was doing. And so I felt it was really time to align with more innovative companies and or disruptive health technologies to really be able to move the needle when it comes to getting away from that insanity and expecting the same results by doing the same thing. I think just briefly what we do is, you showed the slide in the last panel, we certainly do fall in that navigation space. I think we consider ourselves definitely more in the care guidance, full-fledged platform or ecosystem with providing people with accurate clinical information, clinical guidance, and navigation to services that they need at the time that they're having symptoms. I'll stop there so that we have enough time for the rest of the panel.
Okay, perfect. I see Donna next on my panel. Thank you, Adrienne.
Hi, I'm Dr. Donna O'Shea, and I'm from United Healthcare. Yes, so a very large payer. And Adrienne, I loved what you said about doing the same thing over. And I was in practice I'm a reproductive endocrinologist, but also in residency training for many years, residency program director. And it was not only seeing doing the same thing over again, but watching us teach the same thing over again, so that it would perpetuate those type of experiences. And it was hard to make a difference. You can make a difference one day at a time, one person at a time. And I really thought, you know what, we need to, you have to understand the inside to change it from the outside. And so that's sort of how I came into it. And then as I mentioned, I'm from United Healthcare, and of course, United Healthcare, even though we think of it as a big health payer, it also has many arms of innovation, and so that sort of was really fascinating. So even though there's sort of the rock base that is really steady and solid, there's a lot of different opportunities here, and as a member of the UCS Population Health team, the CMO and Population Health and Value-Based Care, we're really driven to that, making sure the experience of the patients are value-based, that they have the right experience, that we can help our providers offer the right service to them, and really the other, another major initiative appropriate for today is that, we are working on different programs, which I'm sure we'll get into later, to try to ensure that every member that we have has a relationship with a primary care provider. That's really important, and we want to help drive that. And so I'm sure, and I think most of that, over a quarter of patients don't have that relationship. And then, of course, with such a mobile population, how do you help it have that relationship and keep that relationship? So I'm sure we'll talk more about that with time.
All right, Andy, you're next on my screen.
I was glad that Donna got a little bit of the dog barking in the background towards the end there, because I'm pretty certain at some point in the next hour, some combination of my dog and my kids are gonna, start raising a ruckus. Great to be here and meet some of you. My name's Andy Elner. I'm a co-founder of Firefly Health. I was the CEO for the first 3+ years and have been the chief clinical officer for the last year or so. I'm a primary care doc by background and identity. Before Firefly, I spent about a decade on the faculty at Harvard Medical School, and the last 5 of those years, I helped to start the Harvard Medical School Center for Primary Care, and had the opportunity to spend a whole lot of money learning about the best models of primary care around the world, and trying to improve primary care within large kind of hospital-dominated integrated delivery systems. But I think, I guess it connects to the, why did I jump outside? I think one of the, I guess I'd sort of take a step back and say, here we go. Here comes the dog and the family just at the right time. I'm glad I teed that up.
Keep going.
My academic home at Harvard was in global health, and I spent the first 5+ years of my career. Hopefully this will die down in a minute. If not, I'll just come back. I spent the first 5 years focused mainly on rural parts of East Africa and the Caribbean, in places where there were, no doctors for hundreds of thousands of people, and going back and forth between there and Boston, where there's 3 doctors for every 1 person, but the care still isn't that good. And so I got really convinced that what was needed was not a small incremental change in how the service was organized, but if we're really trying to get healthcare to everyone, we needed a much more radical shift in the very fundamental way that the service works. And then after spending the next 5 years trying to improve the system from kind of within or adjacent to the system, I think I got sort of further radicalized to the extent that I felt like the best way to accelerate change was to jump outside and build something from the ground up. And so that's Firefly. And to the essence, Firefly sort of differs. We were in that quadrant in telehealth on the last panel, but what's different about Firefly, I'd say many of the first generation or 2 of telehealth solutions have taken on a very narrow layer. They've sort of focused on convenience for, sort of routine conditions like erectile dysfunction or, sinus infections, things like that, which is pretty easy to figure out how to scale. What's really hard is where most of the value and savings opportunities are, which is how do you manage people with complex chronic conditions? How do you really replace what primary care was supposed to be with a service that's continuous, that's proactive, that does the things that primary care was always supposed to do, but never actually has done in real systems. And so that's what we built at Firefly. We replace people's primary care, a lot of their behavioral health and specialty care, with a continuous service. And at this point, we're building out a full health plan offering around our care model. And I'm delighted to have a chance to be with y'all, and happy to talk more about all of the above.
Awesome. Thank you so much. So with that, we wanted to actually talk about the role of the physician as we think about, I'll start with maybe you can do the same round robin in a way to look at what is the role of primary care that you see from your lens, and how does that truly like inform people in the case of Buoy Health, pay for the service in case of United Healthcare, and then from Firefly perspective, solving the hard problems in primary care. So can you share from your perspective, Adrienne, what is the role of primary care physician that you are seeing in your space? Where do you
So I'll kind of use sort of the old adage of the primary care physician being the quarterback of care. I would posit that maybe we need to rethink that, and maybe they're more like the offensive coordinator, and the person or the patient is actually the quarterback. And I say that because, you know, on average, folks are seeing their primary care physician maybe 2 to 4 times a year, if that. And so there's the real important piece of that is the in between the visits and how we're able to maintain, sustain, or regain health in between those visits. And so I think we do a really good job of information exchange, potentially collaborative care planning with the patient at those visits. But that interval 3, 6, 9 months is really going to be important for the person or the patient to be fully engaged and informed about sort of their own care goals, their care plan, so that they can continue to be a really integral member of actually achieving health. And so I would say from our standpoint and our perspective, Buoy Health is very focused on the person who kind of oscillates between personhood and patienthood, so to speak. And so as they're sort of getting sick, we provide information, potentially navigation to services in between their primary care visits. When they're maintaining their health and not having or experiencing symptoms, they can still have passive education around clinical symptomatology or conditions to be able to continue to bridge the information gap between doctor and patient. So I think it's really important as we think about the role of the primary care physician that we think about it in sort of an evolving process. And so going from the quarterback to the offensive coordinator, as I mentioned before, really means involving a whole bunch of other individuals, because I think what we're all trying to achieve is sort of this comprehensive whole person health. And so I think it's almost unfair to the primary care physicians to burden them with all of the responsibility of the coordination for mental and behavioral health, physical health, social health, environmental health, that we all know contributes to the overall health of an individual or their patients. And so having teammates or team members who are able to kind of contribute to that overall sort of care planning and intervention and navigation to the right services or care, or even just kind of social sort of drivers of health that may be improved in the interval. I think that can be someone who is not the primary care physician, but somebody who may be a mental health counselor. It could be a nurse practitioner or an RN who just kind of checks in on a patient in the interval. It could be the pharmacist if they have a good relationship in their neighborhood pharmacy. And so I think the PCP is really becoming more of an offensive coordinator and part of more of a team-based approach.
How do you layer your service in that arena with your AI first kind of navigating tool as kind of powering up that role change for a PCP?
Yeah, so I think we're powering up because we're actually powering up the confidence and the information for the patient themselves. And so we all aspire to have an engaged and well-informed patient, because that creates really fruitful conversations during a visit. When you're able to sort of discuss opportunities and options for how you go about someone achieving their health, or even actually just having some mutual understanding of what's important to that individual around health, because not everybody is one size fits all. What may be important to me for my health may not be the same that's important for Andy or Donna. And so being able to sort of personalize it and customize it to the needs of the patient is really important. But in order to achieve that, the patient has to be informed enough to be able to have a conversation and confident enough to feel like they've been heard and can share their opinion as well as part of that team-based approach.
Thank you. And I would jump through to Andy simply because there is a little bit of a dichotomy between the AI first navigation approach that Adrienne's team is working on and a physician-centric approach, Andy, that you have physician or care team centric approach that you're working on. And how is that different in the role of primary care, and how are you powering that up?
Yeah, I think there's a lot of, I agree with much of what Adrienne said. There's a lot of shared themes. We are definitely not physician centered. We also sort of view ourselves as sort of patient or family centered. And, one of the core, I would say, sort of innovations of what Firefly is moving out of, Adrienne referred to sort of a traditional approach to primary care, which says, primary care is like you have an annual physical, and if you're lucky enough to have a primary care doctor and remember that you had this visit, then you go once a year, and then when you get sick, you try to get in and you can't get an appointment, so you end up going to the emergency room or urgent care. We sort of talk about moving away from the kind of visit-based architecture that I think has driven a lot of inefficiency of every kind in healthcare. And so at Firefly, we replaced the annual physical with 48 clinical touches a year. So on average with our members. And so, we do have some of the, we can layer in some of the same types of AI chatbot type of functionality to make our care teams more efficient. But behind that is real people that you have deep relationships with. And by taking a team-based approach, for every one physician, we have 3 nurse practitioners, 3 health coaches, 2 social workers, and a wide array of specialist consultants that we can pull in at any time. And so what that allows us to do is take care of a vastly larger number of patients per physician with kind of vastly higher quality of care. So our ratio is right now about 1 to 5,000 patients per physician. And I think that's going to increase over time. So, I'd say a lot of the same shared principles. It should be a team. We need to move past a visit-based architecture. We absolutely need to, use AI, various ways of using technology to scale the team. But I guess what I'd say is, at the end of the day, I think what really drives value in healthcare is relationship and trust. And a lot of what we tried to solve for is removing a lot of the administrative barriers and kind of structural barriers that have stood between people and having a real human relationship with a team of providers taking care of them. And what we see then is just extraordinary outcomes, which I look forward to talking about later in the panel.
That's really awesome. One follow-up question is, we do see PCP visits going down, both on the younger side, and I do feel like on the older side, we're still holding strong, but the younger side is definitely going down. And women definitely have a problem having PCP. We heard it in the prior panel, but it's for real. How would you kind of build that up as you're putting all your bets in primary care and building up a team? How would you justify that?
I don't blame anyone for not wanting to. People know that visit is a waste of time, and it's being done for like administrative and billing purposes. And like, of course, people are fed up with those structures that don't make sense anymore. What we find is, like, if the experience is instead, not like, oh, I need a new primary care doctor, like I'm going to book 3 to 6 months from now and not get any care until I go in and physically see them. If the experience is now, oh, I sign up for Firefly, and if I have an issue, I can get a visit within 30 minutes, meet my team. If I send them a chat message, they're going to respond within, 5 to 10 minutes. And it's like my people. Like that experience is like, oh, okay. Like I see the value there. Like, and, I think people kind of, they Google because they can't access like real people that will help them answer questions. And they go to the emergency room because they can't get the right, help when they need it. But, we shouldn't expect people to, like, healthcare is going to continue to be a partnership with people who have spent time, developing expertise about the diagnosis and treatment of conditions. And I guess I don't agree with the sort of idea that the patient is the quarterback. I think it's a partnership. And I think if you sort of leave people on their own to make kind of triage decisions, you're going to get a lot more of the fragmentation and wasteful use of the emergency room and other parts of the system that we've seen for the last couple decades. So I think the right approach is to remove all the barriers and just let people interact with a team that they have a relationship with on an ongoing basis.
Thank you.
I have a follow-up question for Andy on that.
Yes.
Just because you mentioned something about the primary care visits going down, which we showed at the top of the start of the program. But you mentioned, Andy, 48 clinical touch points that you have with the patient. That's replacing the annual, it sounds like the annual exams. What are those? Not all of them. We don't have to list all of them, but what are some of them?
Colonoscopy.
How are you getting those touch points?
How are you getting it?
Yeah, it's over the tech we've built. The majority of the interactions are over chat. We develop care plans for people that are personalized to whatever conditions that they have, and we interact with them frequently if they're working on managing a chronic condition or working towards a lifestyle change. Like, most of our people, want to lose weight. And so we're providing a lot of support around that, or sleeping better, the kinds of things that actually are, more meaningful for people's health than most of the medications we prescribe. And so, we do omni-channel, we'll do phone calls, we'll do video visits, but what we found is you can deliver a really high quality of care, mostly over chat, and using care plans and increasingly sort of modules of content that provide people information about their conditions, help them make decisions, things like that. But it's a very different experience, and it allows us to build deeper relationships and deeper trust with people to have those more frequent touches.
That's great. And now I would like to query Donna on, you've heard both the approaches, this AI navigation to care, and then of course there's navigation through care at Andy's. Would United, especially as you're looking at like getting everyone have a PCP, which is awesome, would you look at solutions like what we have today on the panel as something that your population would care about? And from the flip side, do you see utilization and claims data that kind of gives you that information that people do care about these models?
Yeah, so this has been an interesting conversation. Of course, I mentioned that we do consider primary care really important. They're they really are the backbone of the healthcare system, and if we don't make it so that they can do their jobs, then we're really all going to be in trouble. And so we look at it in a lot of different ways, and and including ways to make sure they get paid fairly. And the fee-for-service model doesn't really pay the right way for primary care, right? Because primary care, is it's really, it needs to be team-based. And I'm not saying the primary care doctor needs to work 24/7, obviously, but it is team-based, and they need to have all the right connections in place, all the right platforms for chats, for, urgent care, for whatever it is. And so we need to make it happen, and we need to pay differently for that, to support that. In terms of, and I was intrigued, Firefly is very much like let me go back to, we recognize though also that not everyone can have an in-person primary care doc, because first of all, you may not have one near you. Second of all, depending where you work, what you do, just getting to a visit, and God forbid you have a chronic condition and need to have continued follow-up to stay well, it doesn't mean that continued follow-up needs to be an in-person visit every time. As Andy said, there's a lot of touch points that can help people stay healthy and have them stay on the right track. And the one annual visit a year probably is not going to keep anybody on track for very long if you have multiple, medical conditions. And but we also recognize that, there are primary care, there are people who have really good relationships. Again, it is about the relationship with their primary care doc. So if you have an in-person doc, we want to make sure that we're helping get those providers on value-based care. If you don't have an in-person doc, and right now we're selling to employer groups, Navigate Now, but you can't, and it allows employer groups to have plans that, okay, if you don't have an in-person doc, you can buy a virtual primary care program that has all of the pieces related to that. It's, and allows you that continuous relationship. And we need to be able to, I think the other thing was we need to make it easier for the docs to, whether you're in person or virtual. I think where we are now is it shouldn't matter in person or virtual. The care experience can be the same, and the virtual provider can decide when do you need to go in to have things done in person. And so there's a lot more we can do now, and a lot more that's acceptable after COVID, of course, because prior to COVID, people were like, oh, you can't do that. You can't do that. All of a sudden now, everybody recognizes the value, and that what you really can do if you put your mind to it.
If you get innovative around that. I have done it. I mean, we shifted from in-person to virtual like overnight, pretty much most physicians did. And we created training videos for clinicians to examine a shoulder, to run an emergency code. Like, people can have a pass out episode during the time. What is the information that you need before the visit so that you can call 911 and arrive to this right place? So those are things to kind of think through as you're doing, but it's possible. And the patients appreciated that, which they were quite skeptical initially, that can you do physical therapy through the screen? I'm like, yes,
right.
It's possible. So back to you.
That's a really good, Archana, because I think people were skeptical around telehealth for a long time. And then they got, we did telehealth in 2020, it went over 50%, 75%. Now it's dropped down to 11% because now it's just telehealth. And we've got to do a lot more advances on top of it, right? We've got to really prove that out, that virtual care is more than just connecting you over video like Zoom. Donna, I'm going to ask you this later, but this is when we start focusing about the patient, because you talked about getting that patient to see their PCP more, and we know that's a challenge. But I want to go first to Andy and Adrienne, because I want to still focus on the different approaches. You guys have different approaches, maybe even different populations. And because it sounds like, Andy, you really want to get more into those who really utilize quite a lot of care and utilize a lot of specialists. So who's the population you're going for? This is for both of you. Who's the population you're going for? And regardless of population, you have to build trust, maybe even particularly for you, Andy. So who's the population, and how are you building trust with the patient consumer?
Yeah, great questions. We sort of from the beginning really wanted to be focused on what we didn't want to be was a solution for the tech elite, because we thought they already had a lot of options, and that wasn't where a lot of the kind of waste was happening in healthcare. So we really wanted to build a solution, that worked for, like working people, and maybe even not just on the coasts. And so we're particularly focused on, we have sort of personas, and one of our main personas is like a frontlines worker. Maybe they work at a bank, or in retail, or in some cases in manufacturing. They're in their kind of early to mid 40s. They have a couple kids. Their spouse works, and they have all the things that many Americans have. They're sort of struggling with eating healthy, managing, multiple chronic conditions, a ton of behavioral health, depression, anxiety, kind of stress management. And so that's kind of one sweet spot for us. We're certainly a solution that younger folks love. We find in general that most of our under 40 population has some type of behavioral health challenge. So really high prevalence of depression, anxiety, ADHD, PTSD, just, and there's such, it's funny, everyone's talking about all the funding for behavioral health, because the reality out there is that most people still can't access care when they need it for mental health care. And so we do a lot of behavioral health, in particular for the under 40 crowd. And then just in general, like I'd say our sort of third persona is the, kind of really complex, the person who has, real advanced medical illness and often comorbid behavioral health or psychosocial challenge. So yeah, that's the population. And then Bambi, remind me, what was the second half of the question?
Well, how do you build trust?
Yeah, so we focus on a couple things. So being reliable. There's just a lot of opportunities to, like, what people haven't experienced in healthcare is like healthcare providers that do what they say they're going to do, and like help close all the loops and, basic stuff, prescription refills, answering questions, checking in with someone who's been sick to see how they're doing. All the tech we've built, it's basically like an intelligent CRM platform where it's helping us manage people over time and ensuring that we close every loop, follow up, on anything that's going on, check in with folks. And so I think just like basic reliability, responsiveness, because we're unlike the sort of first couple waves of telehealth that they're sort of transactional and episodic. It's like, you're sick and you can get some random doctor or nurse for a video visit. We're deeply relational. It's your doctor, nurse practitioner, or health coach. It's your team. And so you develop a relationship with that team, and you're interacting with them. And the way the model works is to sort of deepen that relationship and build trust. And so the natural question is like, really, you can build a relationship without ever meeting someone in person. And I think like 2 years ago, many people might have questioned whether that was possible, but I'm sure all of us can point to many examples in the last year or two of deep relationships we've developed with people that we've never physically met. And then you have that moment where like, whoa, they're way taller than I expected them to be if you ever meet them in person. But we've just found that, that was my biggest concern when I started Firefly was, well, what drives value in healthcare is actually relationship. So how do you scale relationship? And it turns out with a team-based approach and sort of the right technology, you can actually build deeper relationships, or certainly at least as deep as when I was a kind of one-on-one primary care doctor.
So Adrienne, this is your primarily sort of AI care navigation. It's maybe at some point we'll have relationships with an AI bot, very close one, who knows? But going back to the start of the internet, right? You don't know if you're talking to a dog or whatever that was, if you guys remember that. But how do you build, what's your population, first of all? And then how do you make the person comfortable?
Yeah, first I have to say, Andy, when I get the reaction, it's not that I'm taller, it's that I'm shorter than people expected. So I just had to put that out there. So I think when we talk about sort of what our tools or who our tools are really built for, I think Andy really sort of gave a great sort of build up to what we do. And so people, we know, I think 76% or thereabouts go to the internet when they have concerns, questions, or inclinations that something may not be going well with their health. And so that is all across the board, every age group, parents of young children, as well as older adults. And so our tools are not built for a particular demographic per se. It's actually to capture that audience who is trying to engage in their healthcare with specific questions about symptoms or other sort of inquiries around health that they may have at that time. And so our tools, again, fit anyone from the pediatric age group all the way through older adults. And I think the real great thing about Buoy is that the value proposition we offer to our users is not necessarily just around having them avoid expensive care or care de-escalation, but also we know that there's a segment of the population, as we kind of talked about with women, that are avoiding care or are delaying care. And so really providing some timely navigation to make sure that they're actually getting in to see care providers, whether it's their primary care doctor or other level of care that's necessary for them at that time. And so as far as building trust, even though we're AI or a chat bot or sort of in the computer in the beginning of the internet, I think we have built in a number of different loop closures to understand the user's feedback in almost real time, to understand if they've been in agreement with some of the navigation that we've provided for them, also in areas that they may have questions or concerns, or and being able to respond our tools to sort of the needs of the user as well. And so I think that's how we start to build trust. And of course, we make sure, just as Andy was talking about, that we maintain clinical credibility. We have a medical advisory board in addition to some senior clinicians on staff to ensure that we maintain clinical soundness, clinical relevance, and clinical reliability.
Thanks. And Donna, I'm not sure, but I know Buoy is backed by at least 3 insurance. Hopefully it's not United Healthcare, because I didn't see that. I guess it's not. Adrienne, remind me of the 3 insurance companies that you're backed by. Is it Cigna?
Cigna, United, and Humana.
Okay, so United. So Donna, are you using Buoy to layer across your service to drive more engagement with the primary care physician or other specialists they're routing them to?
Well, United's pretty large, so I know we are using Buoy in certain areas. It's not in my area, though. No offense, Adrienne. So it's not in the area that I am in. When we've created our virtual solutions, they've sort of been standalone, so they haven't been. It's not connected to anything else. So. But I do believe as I'm thinking about it, I think Buoy is, I shouldn't say this, but I think it's in one of our portals, or for our members, that they can use it, but it's not directly connected to any of the products I work with.
And how would products similar to Buoy's or Firefly's, how could they be useful at United, or what type of sort of outside services innovations are you bringing in to drive more, to help your members have a relationship with a PCP?
Oh, well, we do link, as some of you may, know that United Healthcare links with a lot of different national telehealth providers, for example, and started. And of course, I agree that the early telehealth providers were really, on the virtual visits, were really more transactional urgent care. They really weren't in this primary care space. So we did start to expand with, actually with Amwell on offering virtual care services. And also we have Optum Care, or Optum Care Ventures. That is another virtual provider group that, so that we actually offer virtual, let me get the number right. We offer virtual primary care in 11 states. And by the end of 2022, I think it's going to be available for about 10 million members to opt into. So we offer that. We also have a new product that's really a virtual care product, and that's the Navigate Now product, which is all in that product. You must, it's built around a virtual primary care provider who's linked in the market. That's very market specific. It's only in 9 markets right now, because it does link virtual primary care with specialists and urgent care and other services in specific markets. So it's a combination of virtual services with in-person, directly linked to in-person services as needed.
So Donna, is that home built, or is that something that you licensed? Navigate Now?
That particular one is home built.
Okay.
Through Optum.
Okay, and then your in-person network is the third layer, basically. So your first is the Navigate Now, and then they build a VPC relationship, or virtual primary care relationship. Yeah. And then the virtual primary care relationship now feeds into the brick and mortar network that you are.
Right. It's a shared, they have shared EMR type.
Okay. Oh, good. Okay.
And of course, that's what's really critical, is having that.
the universe to be
The
connected.
universe, right? But it does mean it has to be very market specific, and that's why we've just launched it in 9 markets, and
Okay.
we've got to make sure that all of the pieces. We want the experience to be for patients, to be seamless, right? I
Yes.
mean, it's the healthcare system's hard enough to navigate, and part of primary care is to help patients experience the healthcare system in the way they need to experience it, and so we need to be looking for solutions to help that happen.
Excellent. Well, I would like to flip our conversation into the provider realm in a way, like getting closer to the providers and starting to see like things like KPIs and what are the outcomes that you're marching towards, and then also how are you protecting your providers from a burnout? And each of the three solutions, one being from a payer, is very unique. And so I would start with Adrienne and looking through like a AI first model. What are the KPIs that you're marching towards? And then how are you looking at supporting providers not getting burned out with too much data?
Yeah, so I think I think the general buckets that we do look at as far as our KPIs mirror some of the things that we think about when it comes to the triple or quadruple aim, right? And so we're thinking about sort of the patient experience or the user experience from our standpoint, lowering the total cost of care, particularly for the patient. And then the third would really be sort of making sure that we are helping them achieve the health outcomes that they've identified for themselves as being really important and relevant to their life. And so I think the way that we sort of address and help achieve and advocate for on behalf of the providers themselves is really, again, kind of getting away from the unfiltered and unnecessary information that's kind of gathered from Google, which may not be relevant to their situations when they're trying to have discussions with their PCP, and having sort of more filtered and curated content and information that can actually lead to more fruitful conversations and lead to better, more trusting relationships between the physician and the patient themselves.
Great, thank you. Andy, I'll go to you next and then come to you, Donna. So it's a two-pronged, like what are the KPIs, metrics that you're looking at as a physician for patients, and then of course, the quadruple aim, which is provider burnout.
Yeah. So what's fun about our model is we can be so outcomes driven because we're not like, traditional healthcare is very input driven, like how many visits have you done, basically. And what we obsess about is, of our hypertensives, what % are under control, of our diabetics, what % are under control, et cetera, et cetera. And what we're seeing is from a health outcome standpoint, we tend to do about 25 to 30 percentage points better than the commercial average for chronic conditions. And we're kind of looking at those KPIs on a daily and weekly basis. From a patient experience standpoint, we tend to be, our most recent net promoter score is 76, and we've kind of gone from there to the low 90s. So compare favorably to more like consumer brands like Netflix and Apple, and kind of do better than them. I think they're usually in the 40s and 50s. And then we look at cost outcomes. We look a lot at, how are we influencing people's utilization of the rest of the system? How are emergency room rates looking? Rate of specialist visits, things like that. And a lot of what we're doing is sort of replacing traditional in-person, expensive, wasteful care with this continuous connection that's focused on, just driving towards better outcomes. So it's sort of fun to see that. I guess that's triple aim, right? In terms of experience, cost, and outcomes. Yeah. And then the quadruple part in terms of kind of provider experience. I'd spent a lot of time in the first phase of my career thinking about this, and like the best kind of studies that have looked at provider burnout say that like what burns people out, people used to think that like low quality providers who are burned out provide low quality care. And what the sort of best literature says is actually the perception that you're providing low quality care that burns providers out. And the combination of that perception and that you don't have any control in making the system work better. And so, what we found is if we put our providers in a system that works, that's designed to sort of close all the loops, that demonstrably is higher quality, lower cost care, and then we allow them to also partner with the product team and the engineers to continuously improve the system, then it becomes a really delightful experience for the providers. And we can do it in a way that actually makes them much more productive and efficient by building the large teams that I described. So 3 nurse practitioners, 3 health coaches, 2 licensed clinical social workers for every physician, and having those folks, it is back to that idea of like top of license, highly collaborative. The physician's role is to, do a lot of get involved in complex cases rather than the like incredibly disparating approach of like, oh, this person's complex, I'm going to send them to like 5 different specialists. What we do is just pull the specialists in and collaborate virtually and make a much more fast and accurate diagnosis in ways that delight the patient and reduce a lot of the wasteful utilization that happens along the way. So that's the kind of quadruple aim part.
Do you capture that aspect of like wasteful utilization or deferred referral and other things through your metrics? Like, do you report on that?
Yeah, we're looking at, every day, every week at kind of rates of specialist visits, emergency room visits, hospitalizations, all of the, kind of standard utilization metrics. And, we see 20 to 40% reduction across the board in those areas. And again, like that's, any good primary care model is going to see those types of reductions. The question is, how do you scale that model? And the way you scale it is you build large teams and you build technology that enables people to function much more efficiently and sort of play the roles that they're best suited to play.
That's awesome. And Donna, in your case, the KPIs that you're driving for your group, especially the PCPs that you are wanting to establish with your virtual group Navigate Now, what are the KPIs that you want them to march towards? And then how are you ensuring that these virtualists don't burn out?
Well, I think burnout is excuse me, is always something we have to watch out for. I think in terms of how the KPIs, one of our going in position is that virtual primary care has to have the same outcomes as in-person primary care. I'm going to have to take a
Yeah, absolutely. Yes.
Let me jump in here because we have to actually wrap it up probably in 3 minutes. So we talked about providers. Let's go ahead and just talk about patients really quickly from the patient side. And we touched on the outcomes. You guys touched on the outcomes and the KPIs, but from the patient side, and Adrienne, you talked about the consumer being the quarterback. Mind blown. We were all focused on the doctor being the quarterback, and then Andy, of course, shifted it back. But anyway, so let's just talk about the patient is the quarterback. They need to be proactive. What are you guys doing with regards to incentives to get patients to be more proactive? And it could be the economics, because if you saw what our slides earlier, this one gentleman, Pete, 55 years old, doesn't see the doctor because he has high deductibles. And so he hasn't seen a PCP in 3 years. So how are you engaging that patient to be more proactive and utilize your care? So Adrienne, start with you.
Yeah, and I think part of that is sort of, and I think Andy kind of alluded to this in the Firefly model, is sort of having ways to engage them and meet them where they are. And so if that means sort of using technology as a way to meet them in the hour and the time that they're expressing a need or wanting to be engaged in that, then I think that helps with that. And so from our standpoint, we know that we are touching individuals who have concerns or questions or just curiosity about their health at least 12 hours prior to any time that they would even reach out to a known primary care physician. And so from our standpoint, it's really integrating into sort of their life in the time and place that they are looking for that information and meeting them where they are at that time.
Great. And Andy, what about you? How are you incentivizing patients to be more proactive?
Yeah, one of the reasons Firefly has been really focused for the last year, we sort of, the first couple of years, we proved out our care model, and now we're building a health plan around the care model. So it's care and coverage, and the opportunity there is to align financial incentives exactly as you said. So there was a gentleman on the last panel that said, hey, I think primary care, we should make primary care free for everyone. Well, that's what we've done. The way that our plan is designed, all the interactions with your primary care team, anything with Firefly is free. You pay no copay. It doesn't trigger your deductible. If you, and then we've built a network, we can navigate folks within it. If you go where we recommend that you go, then that's free too. And so I think aligning financial incentives gives us the opportunity to, help people, help us help, partner. I don't think that, I hope I didn't give the impression that I think the physician alone should be quarterback. I think it should be a partnership. But I think that people need help, and we sort of see ourselves as a fiduciary, not just for someone's health, but their physical health, but also their financial health. And the way to do that is to package it within financial incentives that help people save a ton of money if they use the healthcare system in a rational way.
And Donna, sorry about that. Hopefully,
I'm sorry, no.
So we jumped to how are you driving sort of, this is your point that you made, you want to drive more PCP visits, but problems are high deductibles, so that keeps people away. So whether it's lowering those deductibles, having a hand in doing that, or having some other incentive, how are you driving more people to primary care?
Yeah, I think, it's very much like, as Andy said, although we don't use the term free visits, I will say that as a health plan, it's no copay. So,
Yeah.
But for Navigate, so for Navigate now, part of the driving the premium, and part of the reason for the product is also to drive down the premium for medium-sized employers, and we're trying to. It's a 24/7. Online chat, also all, different access points, and the team structure is absolutely critical. But it's the $0 copay for whether it's physical, mental health, $0 for generics, to try to help engage the patient to, it's not going to cost you to check in, and to stay on your medicines. That copay, those copays for people on medications really add up. So if you can get people on generic medications and not have a copay, well, that, it doesn't guarantee medication adherence, but it certainly helps patients at least fill the prescription. And then if it doesn't cost out of their pocket to check in with the doc, and the doc says, I want to hear from you in a month or two, they're more likely to do that, especially if it can be virtual. They don't have to miss work. And so those that's an important piece, I think, for bringing the system together, is making it affordable and easy for the patient. And then of course the doc has to have that support, but with the technology and docs, I think, as Andy said, if they think they're able to give good care, they're going to be happier, right? So if the patient really does follow up.
From system perspective, we wanted to kind of hear what KPIs that United Healthcare is measuring from, and you mentioned that the VPC or virtual care has the same outcomes that you're striving towards. Is that the same cost also, or is that
same KPIs?
Care?
It's kind
Same
of early
KPIs.
to say for sure.
Both.
So the expectations are the same, right?
Okay.
We want to drive up primary care visits. We think you can reduce your specialist visits. We want, inpatient care, emergency room.
Perfect.
All of the measures are the expectations are the same.
Okay.
All right, Archana, I think we have to wrap this up. We're way over.
Yeah,
We have so many people on the chat and some really great comments. Thank you so much, Andy, Adrienne, Donna. Thanks for joining us. And now we're going to hand this over to Mark Goldstein. And by the way, Andy, Adrienne, Donna, please stick around if you want to listen to the conversation, of course. And I'm going to pass the baton here to Mark for this exciting panel and really innovative companies.
Yeah.
Next.
Welcome, Mark.
Thanks, everyone.
We're the end of the day. So